Namaskar viewers. Today, once again, orthopedic topic, and Dr. Ram is with us once again. And today, the topic he has suggested, not my pick, his suggestion that some 10 years back, arthritis was not so much a familiar term for us. But within this 10 to 15 years time span, it has become a new norm. And one person in three or four has this. Dear friend with him, either a knee or a joint pain or a hand or everything else. So, what exactly this term means? What are the findings about it? How can you identify that you are suffering from this disease? Also, how to manage this and the treatment course, of course. So, all this we are going to discuss today. And once again, thank you for your time, doctor, and Swagatam.
Thank you.
Yeah.
Thanks a lot for inviting me on the program.
Thank you. Pleasure is all mine. So, doctor, as I said in the opening remark, arthritis is something which is a new norm now, and we are finding it in even in kids also nowadays. This term is getting spoken about. So, my first question to you uh, is the knee arthritis different than other arthritis?
Now, arthritis is a very broad term. Let me put it with that statement.
Sure.
Now, as a surgeon, for me, arthritis means loss of joint space, loss of the cushion, what we call cartilage. Now, knee arthritis is similar to spondylitis in the back. It is similar to hip arthritis or shoulder arthritis. Now, per se arthritis, there are many reasons for that. And the commonest form is aging arthritis. As we age, the joints, they do get worn out. The bones get closer to each other, and that results in arthritis. Now, is it different from other arthritis? There are many other kinds of arthritis which can result because of accidents, because of infections, hereditary and genetic disorders like rheumatoid arthritis, lupus, ankylosing spondylitis. However, all these inflammatory arthritis, they do end up in osteoarthritis, which is the end stage. So, as a surgeon, for me, it's very simple. Arthritis means loss of joint space.
Is it one basic question? Is it due to the deficiency of calcium as well?
Not necessarily.
Okay.
Calcium deficiency causes rickets in kids, osteomalacia in adults. It results in joint pains. But as such, it is not the main cause of arthritis.
Okay, got it. So further on this topic, other than pain, what can be the symptoms?
If we take knee, apart from pain, patients complain of stiffness, gradual deformities. Some patients have got bow legs, some have got knock knees. It's a gradual development from normal to these deformities. Apart from that, there can be swelling.
Okay.
Sometimes instability because the joint is worn out. And in some cases, let's say hip arthritis, the pain can be referred to the knee joint, so away from the main source. So that is how we identify joint arthritis after proper assessment.
Okay. Let's say somebody can figure out from the symptoms, but we do not know the severity or intensity of that particular damage. So, what kind of a test or what kind of a findings, clinical findings, do you recommend?
Now, the clinical assessment, of course, is done by the clinician, whether it is a physician or a surgeon.
Yes.
So, by looking at the gait pattern, whether they are walking properly or whether they are limping, whether it's a side-to-side walk. Sometimes there is limb length discrepancy, shortening of one leg, swelling of the knee joint, and reduced joint movement.
I see.
Now, to confirm arthritis, all we need is a simple radiograph, plain X-ray of the joint.
Okay.
That will tell us whether the joint is arthritic or normal.
I see. Okay. All right. Oh, you can figure out from that as well. That
yes. Here, can I show the X-ray?
Please do.
It's there on the system.
Sure, very clear.
Now, you could see here.
Yes, sir.
The left picture is a normal joint. The top portion is the thigh bone, whereas the bottom part is a leg bone, and there is gap between the two bones.
Okay.
If we look at the middle layer picture,
Mm.
the inside there is no space at all. The bones are rubbing against each other,
Mm.
right? Whereas the lateral aspect, there is still some joint space. And the third one on the right, extreme right side shows
Yes.
severe arthritis.
Right.
So this is more than enough for us to tell us how bad the arthritis is.
Got it.
Okay.
Right. Right.
Sometimes when the X-rays are not very clear,
Mm.
and if they're deceptive, then we do get MRI scan, which
Ah.
is which is more accurate in assessing the extent of cartilage damage.
Mm.
So these two investigations, radiological investigations, are enough for us to assess the extent of arthritis and plan the treatment accordingly.
Yes.
Yes. As I said, the CT scans, it has got a lot of radiation, unlike MRIs.
Mm.
And the CT scans are used mainly
Mm.
for assessment of fractures,
Mm.
3D reconstruction images, so that we can plan our surgeries for fracture fixation. It is not the main stream of investigation for arthritis.
Arthritis per se. Okay. Now, how to manage this arthritis?
Now, as I said in the beginning, there are various kinds of arthritis.
Right, sir.
Now, let us start with the basic aging arthritis.
Ah.
If we live long enough,
Mm.
everyone will get arthritis.
Mm.
In some people,
Mm.
where the genes are good,
Mm.
the arthritis might be delayed for a while.
Mm. Mm. Mm.
But in most other people, arthritis starts somewhere between 55 and 60.
Okay.
It is a way of life. Now everything has to degenerate.
Mm.
And it's a simple example is if you use a car, the car tire wears out. If
True.
you use your joints, they will wear out.
True.
There is no way to stop it.
Only thing is we
You
can
got
delay.
other arthritis. You got other arthritis like rheumatoid
Yes,
arthritis,
sir.
SLE, and all. For those diseases, there are special biological medications
Mm.
which are advised by the rheumatologist. Only on their recommendation, those medicines have to be taken because they have got a lot of side effects.
But as I said in the beginning, some 20 years back, it was not such a common disease. Is it
Yes.
purely a lifestyle disease?
Two things.
Mm.
One is lifestyle, and the other thing is because of the improved lifestyle and food, we are living longer. Whether it is prosperity or economic conditions
Mm.
improvement.
Mm.
In the past, immediately after independence, I think the average survival was around 40 to 50 years and then became 50 to 60. Now it is
80.
80.
Mm.
So the arthritis, as it happens in the elderly,
Mm.
as we age, as we live longer,
Mm. Mm.
the incidence is going to increase.
Increase.
One is living longer
Mm.
it causes arthritis.
Okay. That is the
Now
cost we have to pay.
lifestyle definitely plays a role.
Plays a
Our
role.
lifestyles have changed.
Yes.
We don't do physical fitness anymore.
Mm.
We are used to the luxuries and comforts.
True.
What was our main proper food now
Mm.
is all contaminated with various antibiotics, hormones. So you don't get the proper food nowadays.
Nutrition is not there. True.
Right. The other reasons are lack of sunlight.
Mm.
As kids, we used to go out and play in the
Mm.
school grounds.
Mm.
Nowadays, it's all about laptops,
Mm.
gadgets,
Mm.
sit in the AC rooms
AC
in the
rooms.
dark.
Absolutely. Yes.
The lesser the sunlight, lesser the vitamin D, less the bone density. All these lead to obviously musculoskeletal disorders. So these are the two main factors.
Okay. Coming to that, I mean, it's a known thing that vitamin D deficiency is a real big concern nowadays, and you doctors are prescribing the supplements for that.
Yes.
But what I want to understand is there are some injections and some sort of induce mechanisms. How advisable are they, and who should go undergo like that?
Vitamin D supplements are needed
Mm.
if we are not exposed to sunlight.
Is it
Now,
as parallelly effective as sunlight?
not that much actually. Sunlight is the best source.
Best
It
source.
converts a chemical in our body to vitamin D.
Right.
Because of our lifestyles, if we can't go out, If you are not exposed, then yes, vitamin D supplements have to be taken regularly.
Mm.
Vitamin D comes as injections as well.
Mm.
Some people have the notion that you take one cycle of vitamin D and that's enough. It is not like that. Vitamin D has got a half-life of 4 to 6 weeks.
Okay.
So it has to be taken regularly.
Regular. Got it.
Now, there are injectables for arthritis. Yes. Do they have evidence? Not much. Now, let us start with steroid injections for arthritis. They should be given carefully and maybe once or twice. In general.
In general. Okay.
Because steroid is an immunosuppressive medication.
Yes.
So it has a risk of causing infections. Now, they are high, they have got a higher risk if you give them in insulin-dependent diabetics, immunosuppressive patients, patients with history of malignancies in the past who have undergone chemotherapy. So one should be careful about using steroid. It is not a cure. It is only for symptomatic pain relief. Apart from steroid injections, there are 3 other injections which I would like to talk to you about.
Yes, PRP, STAME, and yeah, please.
Yeah. Let us start with the PRP. It is called platelet-rich plasma.
Right.
We take 10 ml of blood, centrifuge it, and take the growth factors and platelets. Now, how effective it is still under research.
Okay.
Now, the viewers should understand very carefully that it is not a cure.
It is not a cure.
It can give symptomatic relief for a while. In some patients, there is no guarantee. And let me be very clear, it is not a guaranteed procedure. It is not helpful at all for patients who have got 100% arthritis where the bone is touching the bone. The space is gone. It's a structural problem. It's a mechanical problem. So 5 ml of platelet injection is not going to help.
True.
Early stages of arthritis, it might help to delay or to reduce the inflammation. So what we see in the newspapers, advertisements nowadays, they mention it as a magic cure, that it is a permanent procedure. It's some TV advertisements say you take 3 injections and for life you don't need surgery. I think that is a wrong way of advertisement.
Promoting a fake thing, yes.
We have to be honest. As doctors, we have to disclose to the patients, yes, it might work, it might not work. And at the end of the day, it is your choice, but we cannot guarantee the result.
And how expensive is that?
Platelet-rich plasma is not that expensive. Okay. It is around 7,000 to 8,000 rupees per session, and we try for 3 months.
Okay.
Once a month for 3 months. That's a recommended protocol.
I see.
And coming to the next injection is what we call stem cells. It's almost similar to platelets. We take bone marrow from the pelvis.
I see.
Again, centrifuge it, take the stem cells and inject into the knee joint. This is much more expensive, costing around 50 to 75,000 rupees. And as I said before, similar to PRP, it does not have much evidence at all for established advanced arthritis. They are safe though. There are no complications as such. So one has to take it with a pinch of salt, talk to the patient, say, if you don't want surgery, if you're not willing for surgery, we can try this with a disclaimer, it might not work. The third injection is what we call viscosupplement injection. Yes. It is an artificial chemical. Okay. It comes pre-packed, 6 ml. Okay. It's what we call hyaluronic acid. Okay. It is a chemical which helps to lubricate the joint, and the companies which manufacture it say that it stimulates cartilage production.
Does it?
Not necessarily. There is no evidence at all.
Once again, okay.
If we look at the document from AAOS, American Academy of Orthopedic Surgeons, which is a big association of more than 3,000 orthopedic surgeons, and the NICE guidelines from NHS, United Kingdom, the recommendations are there in the public platform, on the website. There are no there is no evidence and there are no recommendations either from the health ministry or from the government or from the surgeons recommending these medicines as a cure. Viscosupplement injections in some patients can in fact increase the inflammation. It can cause synovial membrane inflammation, and some patients come back saying it is more painful.
Painful.
It has no significant complications. It is on an average 18 to 25,000 rupees per joint, and it has to be given only once, not more than that. So these are the three injections which
Yes.
have not got significant evidence, but can be tried as a substitute, as a temporary procedure. So one has to be very honest and make it clear to the patient.
And also, not all can afford to spend that much of economically not afford it. And as this is an alternative to the surgery, maybe just for the temporary relief, as you rightly said.
Absolutely, absolutely.
So then the last refuge is surgery.
Yes.
Okay. Okay. Now, first and foremost, there is also a myth that surgeries do not get the success rate as expected. One, and second thing, how many can withstand that surgery?
Yes.
Is also a debatable topic. Now, my question to you is, I did a little bit of homework on your points, and I came to know that there is something called keyhole surgery.
Yes.
And I remember the last session you were talking to me that time, you also discussed about the kind of material used for the thing. So all that we'll talk now. So my first question is, keyhole surgery, is it really beneficial?
If the MRI or plain X-ray shows significant arthritis, then keyhole surgery does not play a big role at all. It is again a temporary procedure where we wash out the painful chemicals from the joint, try to debride it, try to clean up any loose particles, any arthritic osteophytes, loose bodies, and give some pain relief to the patient. Arthroscopy is not an alternative to knee replacement surgery. In some patients where we feel the X-rays and MRI are not very clear, I use it as a diagnostic procedure to assess the joint and then recommend knee replacement if needed at a later stage. But now the incidence of diagnostic procedures which we are doing has come down a lot, as the radiological procedures, like MRI, they are getting better and better.
So you can make the analysis more prominent and more
absolutely
precise.
It's more of a clinical radiological judgment.
Correct. Got your point. So once again, a layman terminology. Knee replacement. So what we say is you take out the damaged one and you put the new one. So please, first of all, educate what does that mean?
You should not call it a total knee replacement. We should in fact call it knee resurfacing.
That makes more sense. Huh?
All right. We are not going to take out the whole bone. We are not going to remove the muscles. Main ligaments are left intact. So what we do is remove the cartilage portion, which is arthritic. And we fashion it in such a way that it fits, the components fit onto the cut surfaces of the bone. Now, there are many advertisements which say we individualize to every patient, that every, it's what we call patient-specific knee replacement. There is nothing like that. Most of the companies manufacture specific numbers, sizes, 6 or 7 at the most. So there is nothing like patient-specific replacement. One has to be very clear about that. Now let me show the model, which for the audience, it makes it very clear. Now this is what a knee replacement is. Looking from the side, that is a kneecap. That is a thigh bone component. That is a leg bone component. If you look from the side, the bone is intact.
Yes.
Right? Yes. Similarly,
Oh,
The bone is intact.
right.
So the bones are not completely cut. It is
Right.
only fashioned at the top 2-3 millimeters,
Uh-huh.
right? And this is how a knee replacement looks like.
Okay.
So these are not solid metal work. They are shallow. They are like caps on your
Yes,
head,
yes, 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 yes.
right?
Mm.
So this is for the thigh bone.
Uh,
This is for the leg bone,
leg bone,
and
yes.
the white portion, which is plastic,
Yes.
replaces the arthritic cartilage and meniscus.
Okay.
So this is how a knee replacement
The
looks like.
replacement is done. Got it.
Okay.
Yes, sir. That's really that's really helpful to understand how does it work. Um,
And when you look from the side, you can see the ligaments are left intact
yes. Got
there
it.
and there.
There, yes.
And the muscle on the front, we don't remove it.
Hmm.
It's all intact.
Hmm.
Okay.
Hmm.
So this is what a knee replacement looks like.
Okay. Before I sleep on to the relevant question or the knee related question, I'm getting one doubt in my mind. Any surgery for that matter is a
Yes.
more like an engineering work and
Yes.
immense amount of skills required to perform it in a proper fashion. How much trust can we have in a surgeon in this matter as a patient?
As a patient, I feel it is one's responsibility to do the research work, to check the background of the surgeon,
Mm.
the hospital, the company, the implants. These three factors, they matter a lot. As you mentioned, all orthopedic procedures,
Yes,
whether it is
yes,
fracture
all surgeries.
fixation or joint replacement, they are
Absolutely.
very precise, precision surgeries. 1 millimeter less, one
Mm,
millimeter more,
mm,
it can cause problems.
mm.
You put it in a different angle, it can cause dissatisfaction and have
Some
unhappiness
kind
to
of
the
damage.
patient.
Absolutely.
It is a skill that we develop over the years. It is
Mm,
not as if I got my degree today, tomorrow I'm going to do a joint replacement. Now one has to do proper fellowship, proper training, and it's a long-term
process.
learning
Learning
process.
process.
You know.
Yes. Yes. Okay. I'm coming from a dentist experience background, so I'm asking this question. Uh, they propose us different kind of filling material and different kind of replacement material according to our affordable capacity and etc. Is
Yes.
there the same thing for the knee replacement also that you have different designs, different material?
Now let us come to materials first and then design.
Okay.
In the last 40-45 years, not much has changed as far as a material is concerned.
Okay.
The standard material has always been steel, chromium cobalt steel alloy.
Steel alloy. Okay.
That has been the mainstay, and the raw material is from one source that goes to different companies. So whatever the material is, it is the same.
Is it good or bad?
The steel has been very good. It has been standard
Mhm.
with no major problems.
Oh, okay.
There are two other materials, what you call the gold knee,
Mm-hmm.
which is gold color,
Mm-hmm.
and ceramic knee, which is oxinium. Now, oxinium ceramic has got good results 20 to 25 years so far. It is bio-inert. It is probably slightly more compatible than steel and slightly lighter.
Correct.
Of course, only one company manufactures it, as it's got the patent. Now, for the audience, gold knee doesn't mean gold material. No, only the color is gold. It is nitrobium oxide. It is a kind of alloy which gives that color.
And it's not visible from outside.
It is not visible from outside. You can call it roll gold.
Yes.
The problem here is the gold knee has not got long-term results. We don't know how it is going to behave.
I see.
That is the reason why I tell my patients, go do your research. There are what we call joint registries. UK, Finland, Sweden, Australian joint registries. Every year they publish the results of different company implants. Check if this material is there on that registry. If it is not there, then I cannot guarantee the result. And always tell them, go with the implant which has got a very good track record.
Successful result. Okay.
It is not the latest or the latest model in the market. Don't go for it because it is going to be used in our body.
True.
New design doesn't mean good result.
True.
One has to be careful about it.
True. Before you get into the design part, I want one more question on this material part.
Yes.
Nobody in India is manufacturing that material?
Yes, we are manufacturing. Indian companies do manufacture.
Okay.
We do have some centers. The issue here is we don't maintain joint registries.
Okay.
So there is no one agency which is collecting the data. It's a very big, diverse country, and the surgeons are not reporting their results back to one particular nodal agency where we can collect the data and look at the outcomes. So we don't know the results as such.
Got it. Okay, now coming to the design part.
Yes, coming to the design, every company has got its own design.
Oh, okay.
Small changes here and there. Of course, the basic function is the same to give pain relief and to make the patient walk properly.
Yes.
Now, are there different designs for different functions? There are some surgeons, some companies which say we got some artificial joints for running, some for sitting cross-legged on the floor. It is nothing like that. There is no special design for different functions. So that is a myth. And it is a way of marketing yourself to the patients.
Yes.
Basically, there are two different designs. One we call ligament sparing and one we call ligament sacrificing. It is up to the surgeon to discuss with the patient, tell about those two designs, and decide what is the best for that patient. As simple as that.
No, but pardon my question, but I still have. Why would patient have an opinion on this? Because it's the surgeon who can take a right call whether this or that, depending on the damage.
Yeah, patients nowadays, they are quite aware. They are well educated. They come to my clinic saying, I want this particular design, this ligament sparing, this company with robot. So it becomes my duty or my responsibility to take them through the whole procedure.
Right. Got it. Okay. So, doctor, every time it won't be a complete replacement of knee, right?
Yes, true.
There could be something called partial also.
Yes.
Okay. So, what is it?
Partial knee is what you call half a compartment. Now, when we look at the knee joint, you've got two main compartments.
Please show the model once again and explain.
Yes. This is a total knee. Okay.
Right, sir.
Now, this is a complete knee replacement.
Yes, sir.
Okay.
Yes, sir.
Now, when we do only one portion, one half, that becomes partial knee replacement.
Okay.
Now, partial knee replacements, the surgeon has to be very, very clear whether it is the right thing to do for the patient or not. If you look at the knee, if there is advanced arthritis in one compartment, most of the times there are early changes in other compartments as well. If one decides to do partial knee, it should be mainly in the young patients. The ligaments should be good. No severe obesity. No other arthritis like rheumatoid, SLEs and all. The functions, the demands from the partial knee are different as compared to a total knee.
Okay.
And if you look at it, once you do the partial knee, the other compartment might get arthritic in 5 to 10 years time.
Okay.
So the patients need to be educated that they might need to take down this partial knee and convert it into a full knee replacement in 10 years time. So the incidence of partial knees is very low in our country because of the financial reasons.
Correct.
Lack of equipment
Right.
lack of training, and awareness to the patient. When we tell them, like, you need partial knee, but you have to come back in 10 years, they say, do full knee replacement
I
for me,
know.
doctor. I don't want to come
Once
back.
again, I don't want to spend money.
So there are constraints in doing partial knee replacements.
Right. Before I get on to the once again the main question, my I have seen some people, who generally are very careful about, rather not careful, very scared rather. Like,
Mhm.
I have arthritis, so I cannot walk. I have
Yeah.
arthritis, so I cannot run. I have arthritis, I cannot sit on the floor, etc. Um, do they really have to be so cautious, or they should actually perform these activities which will make it better for them?
What we say is walking, motion is good for you.
Hmm.
As long as possible, keep mobile.
Hmm.
You need to load your bones and joints. You need to keep your muscles functioning to keep fit.
Hmm.
Now, let us say, take some examples.
Hmm.
If you have a car or a two-wheeler, you put in a garage for 6 months. What happens to the tires? They break up.
Hmm.
Similarly, you have a flat or a house, you don't use it for a few months, it gets rusty. So
But it is
we
already
need,
painful, so they are not able to perform the activities, so they are reluctant.
yes, arthritis pain is not necessarily joint reduction all the time. There
Okay.
is inflammation. So there are some safe painkillers. Get your body weight down, use nutritional supplements. It is good to walk.
Hmm.
Running and jogging will cause more pain, definitely.
Okay.
But simple measures, strengthening the muscles, walk. If it is too painful, use a walking stick.
Hmm.
So you are shifting your body weight onto the stick. You are sharing your weight with the stick,
Right.
and at the same time, you are using your joints. You're keeping them functionally
Hmm.
fit.
Hmm. Hmm. Hmm.
I do get every day at least 3 or 4 patients saying, "I've seen this advertisement, or my physician has said, or my the physiotherapist said, if you walk anymore, you will get
Yes.
paralyzed.
Yes.
It will get worse."
Yes.
That's a very wrong concept, and that is not a good advice at all.
Hmm.
Walking will not cause arthritis. It might increase the pain to a certain extent,
Hmm.
but nothing more than that.
Nothing more than that.
Similarly, walking up and down the stairs,
Ah,
squatting, sitting on the floor,
ah,
it
ah.
increases the joint pressure, it increases the inflammation. So the pain gets aggravated. It doesn't cause arthritis. Okay.
Thank you. That's a very good suggestion. Now, with the advanced technology in every field, medical field has also advanced drastically. I was speaking to oncologist a couple of days back, and then she is in this field for more than 40 years, and she said things have improved drastically. And nowadays, even the chemotherapy is not as painful as it used to be before. So is the case with the orthopedic also. So what I want to know is like the words we call that. Computer assessment procedure, the robotics in the computer. These are the two technologies which are widely used across medical field. Is
Right.
your field also having this luxury?
Yes. Coming to the pain, yes, pain management has changed a lot. Now we use various uh, modalities like epidurals,
Mhm.
regional nerve blocks, and a combination of pain management techniques, which makes a patient comfortable and make them walk the next day.
Oh,
So there is a lot of awareness in us as clinicians as well. Now it is not that painful to do a joint replacement. And some of the pain is based on the patient's personality.
mm,
Some of it is psychological.
mm.
If you are worried before surgery, then the pain perception is a bit higher.
I know. So,
Now, coming to computer navigation and robotics.
yes, sir.
Robotic knee replacement is a one step improvement in technology as compared to computer navigation.
Is it as precise as human interference?
Now, let me come to that.
So,
Robotics will assist the surgeon. They are not as clever as human beings
True,
at the moment.
true.
It might become the most intelligent surgeon in future. It is possible. Now, robotic equipment, there are two kinds. One is where you mark the knee joint as a surgeon and give the points, landmarks to the robotic equipment.
Okay.
It will guide you what sort of cuts to make, how to make, but as a surgeon, I have to do the procedure.
True.
So you don't depend completely on the robotic
Ah,
equipment.
okay.
It's like driving a car. If you depend completely on the GPS, it will take you to the wrong place. So robotics are good in a way that it will guide you, especially in difficult knees, in difficult joints.
Mm,
There is a big advantage there,
mm,
but not beyond that.
mm.
Now, there are some robotic equipments where it only does the cuts. The surgeon will be sitting in a corner. And that is probably a bit more challenging to the surgeon. If the surgeon puts landmarks in a wrong place, then the robotic is going to cut as you have decided. So such kind of equipments can cause damage to the blood vessels, to the nerves. We have known
Mm,
incidences
okay.
where the major artery to the knee joint has been damaged.
Mm,
Now, the viewer should also know that one kind of robotic equipment will be useful only for that company's implant. It
absolutely.
is not a universal guide for all other company implants.
Mm,
So if I'm using the robot from A company, I can use the implants only from A company because the software is programmed that way. I cannot use any other company's implant. The patient should know about this. As far as the robot, yeah, please go ahead.
mm. Agree to disagree. Uh, because I am assuming that the artificial intelligence used for this robotics interference must be tested across available options to make it
Yes,
customized or to make it more suitable for every kind of surgery.
absolutely.
Is it something wrong to expect that or
It has to be a controlled trial across many centers. Now, robotic equipment is very expensive,
yes?
and not only to the organization but also to the patient.
Mm,
So, the feasibility of testing it, trialing it, and then making sure that it is worth using it, we still don't know. It
yes.
is a good tool to use for difficult joints, definitely. Now, there are some myths about computer navigation robotics.
Mm,
It doesn't make the surgical scar any smaller. The scar remains the same. The wound size remains the same. Number one. The pain remains the same. Physiotherapy. There are some advertisements saying there is no need for physiotherapy. It is wrong. Physiotherapy remains the same. It will help you to judge your ligaments, your cuts, and probably there will be a little bit of less bleeding
because of the precision.
because of the precision.
Okay,
So there are advantages,
yes.
and it is a good tool to use only in specific instances.
Mm. So, one last question. The normal surgery and the robotic surgery, what is the cost difference for any one wants to know?
Per knee, it is costing somewhere between 50 to 80,000 rupees per knee,
Mm,
75 to 80,000 rupees per joint.
mhm.
So it's quite expensive. If you look at the implant is around 80,000 to a lakh. So to use the
Robotic.
guidance of a robotic equipment who is like a surgical assistant, it is as expensive as an implant. So it is nearly one third of the total surgical cost.
Got it. Um, One last word of caution to people who are prone to the arthritis kind of disorder or aging for that matter. How
Yes,
can they delay it? One, definitely by physical activities and
yes.
nutritional food intake. But other than that, any kind of supplement, any kind of a medical intervention that you can prescribe?
To delay arthritis,
Sir.
few basic rules. One, keep yourself fit.
Mm.
Now, if you are expecting arthritis around the age of 55, 60,
Mm.
then you have to start taking care from 35 to 40 onwards. It is like putting your money in a bank and expecting it to give you multiple returns over 15 to 20 years. So take care of your weight, look what you are eating, get your health checks, exposure to sunlight, proper hydration, and changing your fitness programs. Changing your fitness programs from running, jogging, weight bearing sports like volleyball, football, to simpler exercises like cycling, walking, and swimming in the later years. So, as we age, the water content in the cartilage goes down. So, it becomes more brittle.
Mm. Mm. Mm.
So it is more damaging and injurious to your cartilage if you keep doing running and jogging on hard surfaces. So, we have to take it a bit gentle
Mm.
and switch over to other kind of fitness programs.
Mm. 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 Mm.
And check your diet, a combination of proteins, vitamins. It's very, very important. Nowadays, I'm operating in some patients who are only 40 to 50 years of age.
Absolutely. Mm.
So obviously, lifestyle plays a big role.
No, no.
So one has to look at it and take the necessary precautions so that the arthritis can be delayed for as long as possible.
Absolutely true. Are there any lucky people who would not get it at all?
There are. I have seen people who are in their late 80s and their joints are pristine, like a 20-year-old. And when I question them, their lifestyle is like any other person. So obviously, they've got good genes.
Yes.
We can't choose them, obviously.
True. Very true.
Yeah.
That's all I had, Doctor. Thank you very much for that wonderful and enriching session.
Thank
Uh,
you, Kedajaru.